I think I'm in the bite. Yes, welcome everybody. This is our Palliative Bite session for May. Just a few ground rules. We are recording this session, so for people who can't join us, we can send the link afterwards. We will be sharing Jo's slides, so you don't have to manically write everything down, but she is going to share a lot of really interesting stuff. Today's topic is palliative care and dementia top tips. And I think it's so relevant as we are increasingly supporting people at home, in the hospice and in hospital with a range of symptoms and ethical dilemmas. I've seen Jo's slides and I know we are in for a treat. And Jo is going to share her screen with us. And welcome, Jo. You are Palliative Care Consultant at North London Hospice and at Barnet General, and have a particular interest in dementia. And thanks for being here today.
Thank you very much. I'm delighted to be here. I'm always more than happy to come and talk about dementia, palliative care, frailty. These are my areas of interest. So yes, I'm a palliative care consultant who works at Barnet General Hospital, and I work for North London Hospice in the community. So wherever my patients end up, I get to stalk them and follow them. And I always thought I would be doing palliative care and looking after young people and transitions, but then I started working in Barnet and Enfield, and we have a huge, large, frail elderly population and a huge nursing home population. So by default, I became interested in frailty and dementia. So what I'm hoping that we will cover, I will be as quick as I can. Oh, my slide's not moving. There we go. So I just want to think about the scale of the challenge, because I think this is a cohort of patients that certainly we weren't looking after when I first went into palliative medicine, and now increasingly we are, and the numbers are quite scary. I'm going to think a little bit about actually how we recognise advanced dementia, how we recognise end-of-life care in this population. And then once you have, thinking about the conversations, the communication, and what we need to be saying and documenting. Touch briefly upon symptoms, pain in particular, and then touch upon eating and drinking, because I think that's one of the most emotive issues and one of the most challenging issues we have with families. Ultimately, the aim at the end of this session is hopefully you will feel more confident in communicating with patients and families regarding advanced dementia. I'm going to talk very quick because I just didn't want to cut anything out, which means I'm simply going to go quicker, but there will be space for questions at the end. So like I say, the challenge is huge. We have got an aging population. We have got people are living longer, but unfortunately, they're not living nice, young, healthy years. They're living those older years where you are not as well, where you have more wrong with you. I think the oldest old, so those considered over 80, is going to triple in the next 30 years. And the majority of deaths are in the older population. I always say that to my kids, like it's a good thing. I very rarely look after young people. Most of the people we care for are older, but this group is going to explode really in the next 30 years. So we've got people living longer and we've got more people dying who are older, and they have complex medical problems. Back in the day, when I first qualified, it felt like people died of one thing, whereas now people die with multiple conditions, and we're seeing more frailty, more dementia. This slide was a study that simply showed as you live longer, you acquire more medical problems. So if we've got an increasing population, they're going to have more medical problems. And the reality is palliative care can sometimes feel like this. People have more than one diagnosis. They have frailty, they have dementia, they have heart disease, they have osteoarthritis, they have falls, they have diabetes. And so actually, it's not their one illness that is necessarily the issue. It's the interplay of all of these different conditions and how one might impact the trajectory of another and how complex that prognostication is. 1 in 20 people between 70 and 79 have dementia. That rapidly increases in the over 80 population. And I told you that group is going to triple in the next 30 years. And in that cohort, 1 in 5 have dementia, going up to 1 in 3 over the age of 95. And in our care home population, at least 70 to 80% of our residents have dementia. So the numbers are huge. I've mentioned people have dementia and they have lots of other things wrong with them. And with comorbidities comes polypharmacy. So we've got a group of patients with complex medical problems on huge amounts of medications, and we don't really know what the implications are of all that interplay of medicines. Back in the day, we looked after people with cancer because we thought they were the ones with the symptoms, but actually there's plenty of robust evidence now that people with other medical conditions, frailty, dementia, heart failure, COPD, also have unmet symptom needs. One of the issues is they also have poor access to services. For example, continuing healthcare. It's much easier to get continuing healthcare in a cancer diagnosis because it's easier to prognosticate. So there's less equity. These people have the same problems, but less access to care and support. And often, if the patient is older, they often have old carers. Their partner is often old. Just before I came on, I was giving advice about an 85-year-old and her husband is 87. And actually, you've got to manage them as a unit, and it is that complexity of managing two frail old people at home. It's a harder group to recognise end-of-life care, but I'll share my tips as to how we do that. And the final challenge, really, I work in the community, I work in hospital. Our hospitals are full of frail elderly people, many of whom have dementia, as are our care homes. So you see headlines like this, you can always rely on the good old Daily Mail to help. Yes, our hospitals are full of frail elderly people, but what I would say in my experience is they're not there through choice. Nobody chooses to be sitting in an acute hospital bed. They're there because the system is really struggling to meet their needs. About 70% of beds in hospital are currently occupied by people who are older, and at least half of them have cognitive impairment. If you have cognitive impairment in hospital, you have worse outcomes. You stay in hospital longer, you've more chance of dying that admission, and you've got more chance of ending up in institutionalized care at the end of that admission. This is old information, 13 years ago, but 13 years ago they did a snapshot and they looked at two hospitals, and they identified of all the patients in the hospital on that day, a third were recognised to have palliative care needs. And most of that group weren't cancer patients, they were actually frailer, older people with multiple medical conditions, people who were bouncing into hospital, having recurrent admissions after recurrent admissions, what we call that revolving door. They're in hospital, they're at home, they're in hospital, they're at home. And when they looked at those transitions, that cohort, often in the people's last 3 months of life, they're bouncing in between the community and the hospital, the community and the hospital, and care decisions are being transferred at that time. So we end up having crisis care, reactive care, rather than planned anticipatory care. And I suppose my suggestion is that we could do this differently. There's another way. For example, if you look at our care home population, older people admitted to care homes, to nursing homes, have a life expectancy of 6 to 9 months. If you have dementia at the point of entering into a care home, your life expectancy is even shorter. People who are richer and fortunate and self-funding go into care homes and live longer because they enter earlier when they're more well. But people who are going into care homes underfunded places have a much shorter prognosis, higher nursing needs and shorter prognosis. So any resident being admitted into a care home, particularly if they are funded and if they have dementia, have a very short prognosis. So at that point of entry to the care home, we should be planning, we should be thinking. We know there's been a shift. I trained back in the day where we had cottage hospitals, but they've closed down. And now you're seeing that complex, frail, older person sitting in our nursing homes. But unfortunately, the funding hasn't really followed, the infrastructure hasn't really followed. So actually, often you've got this very complex group of patients sitting in care homes, but with very limited access to the wider MDT. That is shifting now. There is a shift towards enhanced care home models, but there's a lot to catch up on. When they look at those residents in nursing homes and what's happening, the reality is we can see that about 20% of people die within a month of being admitted to care homes, a third within the first 3 months and half within a year. So you can see entry into care home is a really, really important point for having these conversations. And then in terms of, are we surprised? Well, I suppose my question is, were any of you surprised when Prince Philip died? Were any of you surprised when the Queen died? No, we weren't. We could see it coming. Most deaths you can see coming. In nursing homes, only 4% of deaths were considered sudden and unexpected. About 20%, there was an acute event, so they had a stroke or they had a fracture. A quarter died from a known terminal illness, so often cancer or Parkinson's, when they reach the end of that known condition. But the majority, half of deaths in nursing homes, are that dwindling. Would I be surprised if they died? No. Would I be surprised if they were still here? No. They're just sort of trundling along at that low level. And generally, they just get frailer. They just generally eat, drink less, have recurrent infections, that dwindling model. So actually, we can see you can predict what's coming. And therefore, it gives us an opportunity to think about where these deaths should happen. Should these deaths be happening in care homes? Should they be happening in hospitals? The whole to admit or not to admit. I don't want to deny anyone appropriate care. It's not to say people can't and shouldn't go to hospital when that's appropriate. But I know I will often turn up for my sessions in Barnet Hospital and just see people admitted from care homes who are clearly dying, and it feels really sad that they're dying in that environment. We know if somebody's got advanced dementia and they end up in hospital, they find that very distressing. They're in there for longer, they have a high chance of dying either that admission or in the year that follows. So, hopefully we've made the case for the fact that there is value in trying to identify advanced dementia, that it gives us an opportunity to plan ahead and be proactive in the way that we approach things, and gives us an opportunity to really balance that question: what good are we doing, what harm are we doing, with every choice, with every intervention, and with every possible admission. I think it's helpful just to pause for a second and look at definitions. So we hear this phrase end of life, but what does that even actually mean? Well, the GMC, General Medical Council, define end of life as patients are approaching the end of their life if they're likely to die in the next 12 months. So it's likely, it's not definite, no one knows for sure, but it's talking about 12 months. We're not just talking about those people who are imminently in their last hours and days. You've got this whole broad range. I think it's always nice to just pause and think about, what do we actually mean by palliative care? What does that actually mean? Well, palliative care doesn't have a time attached to it. There's no time frame. Palliative care is an approach. It's simply how we approach helping people and their families have a better quality of life in the context of a life-threatening illness. And we do that by looking at all the issues holistically, physically, psychologically, socially, and spiritually. We accept that dying is normal. We're not here to speed it up or slow it down. And it's a team approach to improving the quality of life of people until the point that they die. So when I hear this person has dementia, I always pause and I always then ask more questions. Okay, well, what does that even mean? Telling me somebody has dementia is meaningless, because they could be somebody who's just been diagnosed, is mobile, independent, still working. I did the NICE dementia guidance, and we had a gentleman on our committee living with dementia, and he was able to contribute in an incredibly meaningful and valuable way to the production of that guidance. So you can have dementia and be living well and functioning independently, all the way along that scale to somebody who is bedbound, doubly incontinent, recurrent infections, aspirations, minimal oral intake. So just telling me somebody has dementia does give me no sense of where they are on that scale. So as soon as you hear dementia, you want to be thinking, where on that scale is that person? Can I get some sense of where they are in their journey, as it were? The reason palliative care traditionally liked cancer was because of this image. People generally with cancer function at quite a high level for quite a good time. You have to be well enough to have those anti-cancer interventions. And then what happens is, over a period of time, the cancer progresses and people start to dip in their functional level. And prognostically, that was always incredibly helpful for us understanding about when things are changing. That red line is that classic heart failure COPD. They're gradually getting worse over time, and they have these acute episodes, these decompensated heart failure, infective COPD. But they bounce back, maybe not quite as well as before, but globally they're going down. And it was always challenging to think, well, when is this the last heart failure episode? When is it the last COPD episode? But more challenging is this cohort of patients, the ones we're talking about today. People with frailty, people with dementia, and they're often functioning at a really low level for a really, really long time. So trying to figure out when that becomes end of life, when they're actually dying, is challenging, but it's not impossible. So you can use the surprise question. Would I be surprised if this person died in the next days, weeks, months? I think the challenge with that is sometimes we're surprised if they do die, sometimes we're surprised if they don't. It's not the most accurate question, but it's always a helpful thing just to prompt to get you thinking. The gold standard framework prognostic indicator, I think, has got some useful prompts to consider. So when I think back to that scale, for me, it's thinking, is this person bedbound? Are they non-verbal? Do they need assistance with all of their activities of daily living? Are they doubly incontinent? Have they got reduced oral intake? Are they losing weight? Have they got recurrent infections? That's guiding me to think, actually, this is somebody who's living with very advanced dementia. In palliative care, we like this, the SPICT tool. Again, it does something very similar. The section at the top talks about general indicators of deteriorating health. So is this somebody who's having recurrent, unplanned hospital admissions? Is their performance status deteriorating with limited reversibility? Are they becoming more dependent on care? Are they having persistent symptoms despite our best efforts to optimize the underlying condition? And then it breaks it down into specific conditions: cancer, dementia, neurological. So again, in dementia, not able to eat, drink, walk without help, difficulty with swallowing, double incontinence, limited communication, recurrent infections. These are all the hallmarks of advanced dementia. And then a lot of you may or may not be familiar with the Rockwood Clinical Frailty Scale. This is something I certainly know that London Ambulance are trying to embed, and lots of trusts are embedding. It's a very useful shorthand language for getting a snapshot of where somebody is at in terms of their physical frailty. So this isn't the point at which somebody is admitted in crisis. This is saying, well, actually, how were they 4 weeks ago? How were they when things were stable? And that gives you some sense of how people are. So for example, my mum is clinical frailty 1. She's amazing, she's fit, she's brilliant, cycles to the village, does her shopping. My dad is clinical frailty 5. He's needing increasing help, and I can see him moving through 3 to 4 to 5. I know 6 is coming. So I've already been having those advanced care planning conversations because I know what's coming. So this is a really useful shorthand for just getting some snapshot. Is this a 85-year-old who is clinical frailty 1, or is this a 72-year-old who's clinical frailty 7? And just that immediately gives you some sense of where that person is with their illness. The truth is, it is hard. Dementia, in one hand, is a long-term condition. It's a long-term progressive condition. But on the other hand, we know you're not going to get cured of it. We know we can't fix it. So ultimately, people will die with or of their dementia. So people often find it, like I say, that blue line, hard to recognize. When does this long-term condition become an end-of-life condition? I suppose what I would say is it almost doesn't really matter about this obsession with trying to get it right. If you wait until you're sure, the only way you can be sure is when they've died. So we need to not be worrying about being sure. And it should be about actually what is this person's care needs, not their diagnosis, not their label, but what are their actual care needs. And then if we have recognised that somebody has advanced dementia and we want to think about their palliative care needs, whose job is that? Well, the brain on the left, I think it's the left, I get my left and right confused, the one with the lots of cogs, that's a lot of you, the generalists. So this is the GPs, the district nurses, the matrons, the care home staff. You are people who know lots about lots of different things. The brain on the other side is allegedly my brain. Apparently, I know an awful lot about one thing, which is end-of-life care. Well, this is palliative care. Palliative care is everybody's job. The scale, as I showed you, is huge. The number of patients is huge. And specialist palliative care teams like myself, we cannot do all of this. We simply haven't got the numbers. So we need everybody out there to be ambassadors for palliative care and dementia. We need everybody to be contributing. And then specialist teams like ourselves become involved when things become particularly complex. So we're doing it together. We're doing it as a team. The majority of the base work done by the generalists, and then the specialist services step in as needed. And our old-fashioned traditional model of palliative care used to be, as a cancer patient's functional level dipped, we picked them up and we stayed with them until the point that they died, because we felt the trajectory was only going in one direction. Frailty and dementia, it dips like this. And so we are suggesting we perhaps need a slightly different model, what we call spells of care. So we might meet somebody, as represented by this green tree, at the point that they're admitted to a care home. They're currently not dying, but we know we can predict what's coming. So we meet them at that point, do some advanced care planning, and then we step away. And then they get an infection and everyone's like, are they going to die? Is it going to happen now? So we get involved again. But actually they recover from that episode, but not quite back to baseline. So we make some tweaks, discontinue some meds, check what their care needs are, but we step away again. And then we become involved again at that final point when somebody's dying. So I think we need to be more willing not to hold all of these patients and actually be willing to dip in and dip out. So, like I say, one of the challenges is recognizing advanced dementia and then recognizing end of life. Well, I think we need to, like I say, not worry too much about being sure. We need to get better at sitting with uncertainty. So, what I would encourage us to be doing is, do we recognize that this person's condition is changing? Do we recognize the possibility that this person with advanced dementia may be near the end of their life? And if so, are we communicating that possibility? Are we sharing and acknowledging that uncertainty with the family? So, for example, given how frail your mum is and how things have been changing, all these admissions she's been having, I'm worried that time might be short. I may be wrong, but I'm worried enough that I feel I need to say it to you to check, do you see what I see? And if we're all seeing the same thing and we think there's a possibility, then actually what matters? What's important right now? Have we put everything in place that we need to put in place? So I think we need to be willing to name possibility, name that change, name what we're seeing, name the elephant in the room, and then sit alongside that uncertainty. Yes, we can still hope she gets better, but at the same time, are we preparing? What I call parallel planning. I think hope is incredibly important to people. Family will never want to give up on the person that they loved. And so people find it hard to completely, unconditionally embrace end of life care. So actually, is there a way we can have our cake and eat it? And I think we can. Yes, I hear you're hoping that your mum is going to recover from this episode and get back to how she was. I hear that hope and how important it is to you. And I'm not here to take that away. But I wonder if at the same time, can we prepare for the what ifs? What if she doesn't recover? Or what if she gets another infection? So you allow that space for that hope, but you prepare for the what ifs. And then I'm not really here to teach you how to suck eggs. I think a lot of this is bread and butter, and you guys know what you're doing. You know how to have these advanced care planning conversations. That said, this is what we need to be doing. Once we've recognized advanced dementia, once we've recognized the possibility that this person is end of life, we need to have conversations. These conversations are the thing that make all the difference. So we need to be listening, first of all. What are the worries and concerns that people have about their family? Are they worried about how dad is going to cope with mum as things get worse? What do they understand? We know we can see what's coming. We know that SPICT tool, the clinical frailty. We know what's around the corner, but do they? What's their understanding? What do they know about the possible prognosis? Sometimes we can see somebody who looks like they've got a short prognosis, and yet their family think they're going to live forever. So exploring what do we think is in that person's best interest? What's the balance of every decision? So I will often say to family, look, we're at that point, we know her illness is quite advanced. So we need to think really carefully with every single choice that we do, what good are we doing? What harm are we doing? And that should be guiding the choices that we're making. People need reassurance that you're not giving up. It's not that we don't care. It's not that they don't deserve hospital. It's just that on balance, I think going there is going to do more harm than good. I think it's going to be distressing for them. And actually, what good is it going to do? They're going to have infection after infection. So I wonder if we need to shift the focus into a slightly different way. If we can't fix the dementia, we can't fix their deterioration, but can we focus on getting their end of life right? I'm sure everybody now has come across him, but in case you haven't, I'm in love with this man. This man is Atul Gawande. He's a remarkable gentleman, even though he's a surgeon and he's American. I hold that not against him. He did a series of Reith lectures, and I would urge you to go and find the third one, and listen to it. It's about 45 minutes long, and it literally changed the way I do advanced care planning. And I was already a palliative care consultant. He taught me how to do it better. And I think this book is remarkable. Again, an essential read. And a bit of a spoiler alert, but really the key message he tried to convey is that as people get closer to the end of their life, they often have priorities other than living as long as possible. So for many of us who are younger, we like the idea of living a big, long, healthy life. But the reality is when people get closer to the end, time is often not what they're fighting for. Getting through that infection, to live a bit longer, to only get another infection is often not their priority. Their priority might be actually about being at home, actually about being comfortable, about not being in pain. And sometimes it's really important to have this conversation with family. Sometimes the patient has reached this point, but the family haven't. And sometimes we need to help families realize living as long as possible may not be the priority any longer. So this is now how I approach conversations. What is your understanding of your mum's situation in the context of dementia? But if it could be with the patient themselves, what is your understanding of your mum's situation? And then I listen. What is it that they know? Have they understood the natural progression of the dementia? Do they know what advanced dementia looks like? Lots of people in the public domain think dementia is a memory illness. So they understand that they forget, but they still don't understand why they're not eating and drinking. There must be something wrong. They don't realize the connection between the dementia and all the other health problems that are happening. They don't realize that reduced oral intake is the natural history of advanced dementia. They don't know that the most common cause of death in someone with dementia is infection. People with dementia die of infections. So if we treat every single one every single time, ultimately people will die in hospital. So I ask, what's your understanding? And then I listen to see what bits of the story do they know and what information is missing. Like I say, a lot of people think it's just memory, but do they realize that in addition to the memory, it's that issues with communication, problems with reasoning and thinking and processing, mobility, physical activity, chewing, swallowing, continence? Do they realize it's not just the memory loss? Do they realize the weight loss, the frailty, the pressure sores, the communication, the proneness to infections? This is what advanced dementia looks like. People often focus on dementia and the behavioural problems, the memory issues, and often in earlier stage, these are the key issues, that wandering, when somebody's physically well and they can still wander, they can still get out of bed, the behavioural issues are the biggest problem. But actually over time, what happens is some of those behavioural issues become less because the physical frailty increases and those physical problems take over. People become bedbound, doubly incontinent, reduced oral intake. So I want to see what bits of the jigsaw puzzle do they have in place? What do they know and what bits are missing? What bits of that jigsaw do I need to help them understand so they can start to see what I see, which is that their mum has advanced dementia, that actually I think her prognosis is quite short, and that I worry about the burden of some of these interventions. So then, once we've clarified their understanding, we can then go, well, what does matter then? What is important to you? What would be your worries for the future? What do you think your mum would want? What do you think she might not want? What outcome would be unacceptable to you? What matters? And it's not uncommon at this point that people will start to understand the penny drops. And they might start to say things like, well, she wouldn't want to die in hospital. She'd want to be at home. And that then helps catapult you to all those things we know we need to do and all the things we want to get in place. But we've come at it from a humane angle, a place of care. So from that conversation, you can then talk about, okay, where do they want to be cared for? Where do they want to die? Have we got all the paperwork in place about the DNER CPR so that we're not trying to prevent a natural death? Have we completed a universal care plan with the key information? Have we got the equipment? Have we got the care in place? What about the carer? What do they need? Physically, what support do they need? Emotionally, what support they need? Have we got the right medicines in place? Have we got the drug chart, the referrals, all that personalised plan? Okay. So that's that. That's recognising and conversations. Now, a quick whistle-stop tour of symptoms. You often hear people say, well, how would I know they've got dementia? Like somehow they can't give us the clues as to their symptoms, but often they can. Actually, often we will know, and there is things that we can do. As people's ability to communicate with words reduces, you may find there's an increase in other behaviours or a change in other behaviours, and that may well be a reflection of distress and pain. So somebody being agitated, confused, wondering, pacing, calling out, aggressive, We can't just say, well, that's just their dementia. That's part and parcel of the dementia. That actually may well be them attempting to communicate an unmet need. And if we can figure out the cause, we might be able to do something about it. Back before med school, I worked in a care home for people with disabilities, and we had a young woman who would get very aggressive and would hit her head and hit anybody and rub at her belly until somebody put 2 and 2 together and clocked it was once a month. And then we finally realised once a month she was getting her period, and once a month she was suffering with symptoms and she was unable to communicate it other than hitting herself and other people. And once the penny dropped, we could do something about it. So if people cannot communicate and they are becoming agitated and distressed, they may be trying to communicate an unmet need. So we need to be assessing people. If you are meeting somebody with dementia who can still communicate, then ask them, self-report. I've heard people dismiss it. They're saying they're in pain. They're consistently reporting pain in the same place. And you look through their notes and they're known to have back disease, but people are saying, oh, well, they don't know what they're talking about. Actually, they may well do. So we should be asking people, but keeping it simple. Is it sore? Does it hurt? Then asking family and carers, people who know the person best, and not just, well, they look comfy at rest, that's great, but how about when you move them? Do they become distressed then? And there's lots of really useful pain tools out there. Here I use PainAd, other places use Abby. The tools are all incredibly similar. It doesn't really matter which tool you use, but I'd encourage you to use the tool. And the tools encourage you to, for people who are non-verbal, to look at things like, what does their face look like? Are they grimacing, clenching? Are they rubbing a particular part of their body? Are they guarding? Are they comfortable at rest, but it's when you move them? And then what do we know from the past? What has their body and behaviour told us in the past, like my young woman, where we realised once a month she was behaving in that way? Or is there something that they always do? So I knew he was in pain because he was moaning and trying to scratch his tummy. Often carers, those who know their person best, will recognise those signs. So if you think somebody might have pain, then it's worth thinking, well, what's the cause? Sometimes you can fix the cause. Is it actually that they've got ill-fitting dentures because they've lost weight and they've got sore gums? Is it that they're having problems going to the toilet? Are they constipated? Is it painful joints? Is it an ingrowing toenail? Is it earache? So always thinking, is this pain? What might the cause of that pain be? I remember asking a GP to prescribe end-of-life meds for some patients in her nursing home. And she said, yeah, I'll do all the others, but I'm not going to do the analgesia because people with dementia don't have pain, which I thought was quite a broad, sweeping statement. The reality is evidence shows people with dementia do have pain. Pain is common, and the evidence shows it is underreported and it is undertreated. They did a comparison of people with dementia and people without dementia who had hip fractures. And what they identified is that even the people who were able to articulate their needs were undertreated for their pain. And those people with dementia who couldn't articulate were on about a third of the equivalent of pain relief of this group. So even when you can say we weren't giving enough pain relief, but for this group, they were getting much less. So actually, yes, people with dementia have pain, but it's unreported and it's undertreated, which is unfortunate because actually usually there is something you can do for that pain. It depends on the severity. It may be something simple like moving them, changing their position. For our young lady, we did aromatherapy massage. It might be a cold compress. But if in doubt, a trial of simple analgesia is the way forwards. Always doing things as a trial. We'll give this drug, we'll see what good does it do, what harm does it do, and we'll see where we're at in 2 weeks' time. If somebody appears to have pain all of the time, putting it on the PRN section of the drug chart is not going to be helpful. They're not going to access it. So if in doubt, give a trial of pain relief and give it regularly. If they can swallow and it's not a problem, that may be paracetamol. If they can't, and if swallow is an issue, sometimes we just use a low dose Butrans patch and then we reassess using the pain tools to help us. And actually evidence shows most people don't need big, dramatic, strong doses of drugs. The majority, simple paracetamol or low dose opioids will deal with the majority of pain in the patient population with dementia. That there is just a screen grab of the dementia guidelines, which effectively is everything that I've said. If possible, ask people about their pain, use self-report, do a clinical assessment like you would with anybody and use structured tools, and then take a stepwise approach to managing their pain, using the analgesic ladder and always looking at what good are we doing, what harm are we doing and reviewing it. Then if it's not pain, but there's still behaviour that's challenging and it's been a change and it's something new, looking at why that might be. Are they anxious? Are they bored? Are they frustrated? Are they cold? Are they thirsty? Are they hungry? Working our way through that checklist. For some people, it's not something simple. It's not something that can be fixed and reversed. And there is a cohort of people with dementia who have behavioural and psychological symptoms of dementia. So you've checked that it's not pain. You've checked that they're not constipated. You've checked they're not cold. They're not hot. And ultimately, no matter what you do, you've got somebody who might be aggressive or agitated or shouting out. And that may well be a direct experience of the dementia. Well, the advice again from the NICE is make sure you've ruled out reversible causes. Make sure you've adequately looked at things like pain and delirium and constipation. Where possible, use a non-pharmacological approach. Does distraction work? Is there changes I can make in this environment? A friend of mine, her grandmother was a walker, had always walked 5 to 10 miles a day, and then her dementia got so bad, she needed to be placed in a care home for her own safety. But she needed to walk, and she was very agitated and very distressed, but once they allowed her to walk and they found a way for her to do that safely, her behaviour dropped. So it is knowing something about who is that person and what works for them. Sometimes, despite everything, despite all our attempts at personalised care and addressing reversible elements, people will need medication. But there has been a shift towards trying to avoid medication unless it's absolutely essential. So really, drugs like the antipsychotics should only be used if people are at risk of harming themselves or others, or if their distress is incredibly severe. And then if you are using those drugs, we need to make sure we use low doses for a short period of time and review, does it work? Often they don't work. And what happens is patients get put on these drugs and they end up staying on the drugs because nobody's reviewing them. So low doses, short period of time and review, is it actually making any difference? Okay, nutrition. I think this is one of the most emotive areas because we know people with advanced dementia will always end up developing feeding problems. They will lose weight, they will start aspirating, and family find it incredibly hard to watch their loved one not eat and not drink and deteriorate. And they always think that's something that can and should be fixed. But we know difficulty eating, so the mechanics of swallowing, the coordination, the complexity of that is a marker of advanced illness. And having no appetite, having no interest in eating is a normal feature of end of life care for any condition. And then aspirating is a real marker of end stage disease. So the question then is, can we do anything about that? And whenever I ask myself, can we, then I also ask, should we? Just because you can doesn't always mean you should. So family will often say, but they're starving to death. And I think it's really important we hear that and we acknowledge what we're hearing, but that actually we stick to the reality of the situation. So often family are asking for artificial nutrition and hydration. Now, we're not talking about basic care. Basic care is offering sips and food and drink, whereas feeding tubes and PEG tubes are considered a medical treatment, not basic care. So we have to consider them in the framework of medical ethics and law, always thinking what good are we doing and what harm are we doing. So people will often say, if they're PEG fed, they're less likely to aspirate. It's a safer way of eating. But actually, you can feed through a PEG tube, but that isn't going to stop people actually aspirating their own saliva. If they can't swallow food, they also can't swallow their own saliva. So you put a PEG in and they still aspirate their own saliva. There's no evidence that actually PEGs reduce the risk of aspiration pneumonia. A lot of people think, well, they're starving to death. So if you put the calories in, they'll stop losing weight, they'll get stronger, they'll function better. But again, actually, that is not what happens. That's not how the evidence plays out. So even if we attempt to pour calories in, it doesn't seem to make a difference to people's ability to maintain weight with advanced dementia. Survival. Feeding people, often family think that they will live long, but there's no evidence that people live longer if they have a PEG tube. Pressure sores, people think, well, if they've got good nutrition, then they're less likely to develop pressure sores. But actually, for some strange reason, the reverse is true. And they wonder if that's because to be PEG fed correctly, you're supposed to be sitting upright, and often it's continuous for many hours, and that often worsens pressure sores. And then a lot of people say, well, they're getting weaker, they're getting tired, they're less able to do things, and that's because they're not eating. So if you fed them, surely they'd function better. But again, that doesn't play out in the evidence. There's no evidence that people's strength and function improves. And there's no evidence that the patient themselves feel better. The family might feel more comfortable with finally doing something, but actually the patient themselves don't feel any better. And there are risks, there are harms. So the procedure itself is risky. It requires sedation. People are at risk of just aspirating during the procedure. They're at risk of bleeding. They're at risk of infection. A lot of the time, people then have to be restrained because they tend to pull at the tubes. Their mobility might be reduced. And then one of the big problems that I see is diarrhea. That the protein-rich nature of the food that we give causes diarrhea. So people don't do better. If somebody has reduced nutrition, either because of dementia or even not because of dementia, if somebody has reduced nutrition to the point they can't meet their nutrition need by food by mouth, and you're considering a PEG, they are already a very unwell group of patients. So the death rate, mortality rate, 1 month after a PEG tube going in of somebody with advanced dementia, 50% are dead within a month and 90% are dead within a year. So this is already a cohort of people who have a short prognosis, and we should be more focusing on advanced care planning. I just share with you, when we did the NICE guidance, we made this decision aid, and this was aimed at healthcare professionals talking to family members about the pros and cons. And essentially, this is the why we don't stick feeding tubes in people with severe dementia. And it's a very useful leaflet to use with family members if they're really struggling with that decision. You can find that on the NICE website. There is the odd exception where you might stick a PEG tube in somebody with dementia. If you remember back, I said dementia is a scale from people who are functioning incredibly well to people who are bedbound. So if somebody has early stage dementia, good quality of life, functioning really well, and they get a treatable head and neck cancer, but the radiotherapy is going to make it hard to swallow, we might stick a temporary PEG in where you do that radiotherapy. So there can be certain situations in which you do, but for the majority of people, it's not appropriate. So if we're not doing something, I want to know what we are doing, because I think when you're saying to family members, we're not doing this, we're not doing that, there's nothing more we can do, I don't want to hear that. There's always something we can do. So what can we do? Well, we can acknowledge how hard this is. I can see why you feel like they're starving to death, but they are not. They are dying of their advanced dementia. And if I could fix this for you, I would, but I know sticking feeding tubes is not going to make them feel better. It's not going to make them live longer. It's not going to make them stronger. This is part and parcel of the dying process of dementia. So really, anything that goes by mouth should be about pleasure. If they want ensures, great, but if they don't, that's absolutely fine. I don't mind what they eat, what they drink, as long as it gives them some pleasure. We are now moving to a stage where we're risk feeding. So if we're risk feeding, we need robust advanced care plans in place, because people are going to aspirate. They're going to get an infection. So what are we doing? Are we treating that at home? Are we treating it at hospital? One of the things I see we do is when people start to struggle with their medicines, we make everything liquid in medicines. Well, firstly, it's really important to be aware of the volume of some of those liquid medicines can be very huge, but also the taste of them. Some of them is awful. I challenge you all to go and try and track down some liquid sodium docusate, the laxative. It is truly the most horrific thing I've ever been asked to taste. So switching something to liquid isn't always the kind thing to do. The better question is, do they still need this medicine? Do they still need the statin? The majority of the time, the answer is to stop the medicine, not change it to liquid. There will be the odd medicine that is essential for symptom control for quality of life, and they're the ones that we want to focus on. If you get conflict, some families have very, very strong views. I work in Barnet, which has a huge Jewish population, and sometimes we have lots of cultural challenges around the issues around feeding. The most important thing to do is listen, hear those worries, hear those concerns, and try and share what we know and share this information. Have a case conference, bring the family together, make sure they're all on that same page, bring in spiritual support if we need to. If in doubt, get a second opinion. You can get INCAs involved, and if need be, end up at the Court of Protection, but it's incredibly rare to get to that stage. Patients and families can't insist on treatment. What they generally need is good explanation. They need to understand why we're making the choices that we're making and the recommendations, and that we're always trying to do right by the person that they live, but we've got to think, what good are we doing and what harm are we doing? So, key messages. Hospital admissions are really distressing and are associated with poor outcomes. Most deaths aren't sudden. You can see it coming. Most people die with an infection with dementia. If you treat everyone in hospital, they're going to die in hospital. As people become increasingly physically frail, it is a marker that that dementia is reaching those advanced stages. We see that, but what do the family know? What do the care providers know? And actually, that's an opportunity for us to plan ahead proactively. With every single choice, think what good are we doing? What harm are we doing, particularly in relation to hospital admissions? But every choice, feeding decisions, every drug, every medicine. A lot of people with dementia do have symptoms, and we should go looking and we should be assessing. But the good news is they're not particularly hard to treat when you do find them. Getting that extra information from family and carers is really, really important in somebody who can't articulate. If you see a change in behaviour, always think, is there a symptom? Are they constipated? Are they in retention of urine? Have they got pain? Pain is common and it's undertreated. If in doubt, do a trial of pain relief. When people are having feeding problems, that is screaming out this illness is advanced. I know that. Do the family know that? So we need to make some decisions. We need to have some conversations. We need to document that and we need to share it. Ultimately, one of the key things for anybody with dementia is just being kind in their presence. There's a bookcase analogy about how you've got a wonky bookcase, an IKEA bookcase, and that's got memories. And when you wobble it, they all fall off. But the bit of the brain in the dementia that deals with emotions and feelings is a really, really solid oak bookcase. No matter how much you rock it, it doesn't fall off. So when you are in the company of people with dementia, hold that in your mind, that how they feel in your company will stay with them. So the greatest gift that you can give to people is a sense of kindness and compassion. Hopefully, that's the end of the slides and there is time for some questions.
Well, Jo, thank you so much for sharing your wisdom and information. You covered so much in 45 minutes or even 43 minutes. You covered the background, symptoms, assessment, communication. We're also big fans of Atul Gawande. So we share a lot of your thinking. And I think you will have helped many people today in some of the conversations and the challenges around pain, feeding, and behavior. So I have a few questions, but only one in the chat box. I think you were too compelling for people to put things in the chat box. If we do have to resort to antipsychotics, and sometimes sadly in the inpatient unit where difficult agitation is an issue, what would be your first choice?
It's a good question. I think that if somebody is in the more advanced stages, more end of life, then I tend to stick with our traditional end of life medicines. So we tend to use haloperidol first line, levomethormazine second line. If I've asked to give advice about somebody who doesn't look like they are dying, but they have dementia and it's becoming challenging, but it's slightly earlier, then I tend to stick with the more geriatric antipsychotics, so risperidone and quetiapine. So I kind of have this deciding moment in my head. Do I think they're dying and we'll just stick with the drugs we're familiar with and everybody it's just safer and easier and they're going to be on injections and anticipatory meds? Then that's my stuff. But if it's somebody who, you know, that spells of care, the green tree, the yellow tree, the red tree. So for red trees, I'd be doing haloperidol and levomethormazine. For green trees, I may well be saying whatever is the preference of that GP, or if you've got a psychogeriatrician, and they tend to use things like the risperidone and the quetiapine. Truth is, doesn't matter, actually. Use a low dose, go slow and review. But that's how I divide it.
Okay. Thanks a lot. Now, there are no other questions in the chat box, but we really would like Jo has covered so much. It's hard to believe that there are no questions because you can unmute yourself and ask Jo anything or ask the audience. So I'll wait for a second. You can wave your hand or well, actually, I can see you there, Katie. One of my questions is how can we make end-of-life care for people with dementia who do land in hospital? How can we make that kinder or better? How can we have hospital or dementia-friendly hospitals?
It's a really good question. I know where I work, they have one ward, large ward, that's brilliant. It's lovely. The whole ward is decorated fabulously. That's fine. But given that I said to you about 70% of the hospital beds are full of people who are old and frail and who have dementia. You need it across the whole hospital. So it's nice to have a dedicated area, but actually you need that culture across the whole of the organisation. So I think actually it's little things like at our hospice, we decided we wanted to become more dementia friendly or dementia ready. So we did dementia friends training, and we rolled it out for all staff and all volunteers. So, and that's where I got the bookcase analogy. That came from the Alzheimer's Society Dementia Friends training. And so we've tried to deliver that to as many of our staff. So I think changing the culture and changing the approach of more people will have more impact than necessarily having a ward that has old-fashioned pictures on the ward or that has signs. We did also make some changes like that. So hospices, traditionally, we want to look like somebody's home, and we pride ourselves on that. But in terms of dementia friendly, it's not particularly dementia friendly. To be physically dementia friendly, you actually need a picture of a toilet on the door of the toilet, not just the word. You need to be quite visual with things. You need things to occupy people. So they have a lot of fiddle baskets on our ward. Often people have got that fidgety fiddleness. We get people folding leaflets for us. We put them to work. And then trying to find out actually what music it is they like. You know, people think it's Vera Lynn. It's not. The generation is getting older. So you just need to think about all of those things. The other thing is letting family in if possible. There's a document called the Triangle of Care, and it talked about the fact that actually we'd all make our lives much easier if we let relatives come in at lunchtime and feed their loved one, because A, we haven't got the staff to sit there and feed them, and B, we don't know how to feed them. Again, my friend, the grandmother who was the wanderer, broke her hip and ended up in our hospital, and she started getting aspiration pneumonias. And I said to my friend, look, Lou, I think your grandmother's dying because she's getting these recurrent infections. She said, Jo, you might be right, but I think it's just that your staff don't know how to feed her and we do. And I said, well, I hope you're right, Lou, but we put all the advanced care plans in place, and she got discharged and they went back to feeding her. And that was 3 years ago, and she hasn't aspirated since. So they were right. They knew how to feed her and we didn't. So I think actually to be truly dementia friendly, without burdening family, let them be involved if they wish. Have as many of your staff being dementia aware. It is about kindness, it is about compassion. And then it is about the environment, using pictures, using distraction techniques.
That's a great answer. You've just reminded me that some hospitals still have protective feeding time where visitors aren't allowed, which seems so counterintuitive, as eating is such a social activity, and having families come in to help in our staff depleted wards must help.
Absolutely.
Great. I wonder, I know you work in the community in the catchment of North London Hospice. Do you have any contact with Admiral nurses? Is this something that should increase, or should we all know everything you've taught us?
I think that we should definitely have more. The number of patients that are going up and living with dementia is going to go up, and we need more Admiral nurses. Admiral nurses' main focus is actually supporting the family. So I think we do need them. I think one of the challenges, we tried to make links with our local Admiral nurses, and the scale was what got in the way. They were quite overwhelmed. So they were often involved at memory clinic at the point of diagnosis. And one of their main tasks was to go through there was a post-diagnostic checklist that they had to go through. And that would take about an hour, hour and a half, 2 hours. So trying to then slip in our bit about thinking about the future in advanced care planning was just too challenging. I think that people often have a catastrophic emotional reaction to getting the news, and sometimes trying to do advanced care planning right at the beginning is too difficult because they're having a catastrophic reaction. The challenge then is there's a big void in the middle until people become problematic and start getting recurrent admissions. And it's this void in the middle. And that's kind of where the Admiral nurses sit. They sit at the diagnostic point and then giving a little bit of signposting support to family members. But I do think we need to try and work alongside them. We were offering to do slightly lighter touch advanced care planning workshops with carers, so a bit further down the line, not focusing necessarily on drugs and MAR charts, but that bit earlier, thinking about lasting power of attorney, thinking about caring needs, thinking about pets, thinking about wills and funerals, trying to encourage that bit of advanced care planning. So we did do some joint working with some of our Admiral nurses trying to deliver that, but they were quite resistant, actually. They were quite nervous about letting palliative care in.
And I think, yeah, that's interesting. I think we need to be a bit more rigorous with the Mental Capacity Act. We often see people bundled between hospital, hospice, home, people who haven't got capacity, and yet we are not recording that we're acting in people's best interest or doing proper assessment. And so few people have a lasting power of attorney that's been started early enough to get consent. So those are some of my learnings. I was really shocked by that piece of research that showed that some people had 67 transitions towards the end of life. Yeah. So sometimes I wonder about people coming into the hospice and then we have to move them on to care homes, and that's always a traumatic move. Yeah, so if we assessed, so one of our indicators should be as few transitions as possible, I think, one of our KPIs.
Yeah, and I think we certainly had that as one of our target KPIs, was looking at trying to reduce the number of recurrent admissions in the last 3 months of life, was set as one of our KPIs.
Yeah.
I think the other thing to speak to is risk, sitting with risk, and that's where the Atul Gawande book, I think, is incredibly useful. I think that you've got the person living with dementia, you've got their family, you've got us as healthcare professionals, and sometimes our desire to minimize, reduce, eliminate risk means that we really take away living from people. And I think it's a really, really difficult thing with families because they just want their loved one to be safe. But in doing so, sometimes we deny people their freedom and their choices. And so that's I used to do a frailty MDT alongside a geriatrician, and we both read Atul Gawande at the same time, and you could tell because within the space of a week, the way we approached the MDT changed. And I think that we had been a little bit too trigger happy with saying people needed to be made safe. And I think that as a society, we need to try and find a better way to sit with risk and help families sit with that risk. But it's difficult when they're the ones living with it. And, they need somebody to call at the end of the line, at the end of the, when something goes wrong. So I think naming it and having a conversation about risk and how much risk people are willing to live with is quite important. And showing people there's a flip side to it. So yes, it may make us all feel better if we make them safe and if we lock them up and what have you, but what is that costing them?
I think that's a really good point to end on. Atul Gawande hasn't written about mortality and death and dying for a long time, but I came across an interview that he did very recently, and I'll send it to everybody who's registered, and to you, Jo. Thank you so much. I think your patients are very lucky to have you, and thank you for opening our eyes to what we should be looking at with our patients living with dementia, living and dying with dementia.
Pleasure.
So thanks so much. Thank you, everybody. You've all been very quiet, but I'm sure you've all learnt a lot from this session. And we'll see you again in June when we've got Dr. Catherine Mannix talking to Palliative Care Bites. We will circulate the date. Thank you. There's lots of thank yous, Jo, coming in the chat box.
I'm just glad I went before Catherine Mannix and not after her. And I see you've got the lovely Katie Cordwell.
Yes, in a very nice red dress. Yes, we definitely have Katie in Hillingdon.
Hello, sorry, I was trying to work out how to use the chat. So nice to see you, Jo. Thank you.
You too. How are you?
Yeah, I'm very well, thank you. That was a brilliant lecture. Thank you. I didn't really feel I had a great deal to kind of add because you